Hi, I'm Dr. Joe Suker with the Arizona Trauma Association, and this is Trauma in a Flash. Joint dislocations are common reasons for emergency room visits, and shoulder dislocations amount for nearly half of all traumatic dislocations. Anterior dislocation is the most common pattern, accounting for nearly 95% of all shoulder dislocations. This occurs due to blunt trauma with the arm abducted, extended, and externally rotated. It is often seen in combination with labral tears, greater tuberosity fractures, or fractures of the humeral head. In the elderly, it is more commonly associated with rotator cuff tears. The head of the humerus impacting the inferior edge of the glenoid may cause a divot or flattening of the humeral head. This is known as a Hill-Sachs lesion. A Backart lesion refers to a tear in the anterior inferior labrum of the glenoid rim. Posterior dislocations are more often the result of seizures or electrical shock injuries and can be missed on plain film x-rays due to the direct posterior dislocation of the humerus from the glenoid. Signs include lack of external rotation of the shoulder, with the patient appearing to have their shoulder in a locked internal rotation position. An axillary x-ray view is usually necessary to make the diagnosis. The reading usually will be described as having a reverse Backart and/or Hill-Sachs lesion. A physical exam should include a focused, detailed neurologic assessment to determine if there is associated axillary nerve injury. This is noted by a decreased sensation overlying the deltoid area and weakness of shoulder abduction. The axillary nerve injuries are noted in 3 to 40% of shoulder dislocations, with a higher incidence noted in patients over the age 60. Most axillary nerve injuries resolve completely without any intervention. However, there is a small fraction of patients with high-grade injuries that will experience a chronic functional deficit. Risk factors for high-grade nerve injury include proximal humerus fracture, scapular fracture, vascular injuries, a shoulder reduction that's more than 2 hours after the dislocation, and deficits that include additional brachial plexus palsies. Patients with symptoms of nerve injury should be considered for MRI and referred to specialty consultation immediately, as some high-grade axillary nerve injuries are amenable to early surgical intervention. In our next video, we will cover one technique that shows easy reduction of an anterior shoulder dislocation utilizing moderate IV sedation for optimal patient comfort. Thank you for watching this week's episode of Trauma in a Flash.